wiping the area with chlorhexidine, putting a dot with a magic mark right where I want the implant to go. Now, how do you gauge this? I look at the angulation of the adjacent teeth, and I want to stay parallel to that. So I'm going to use my pilot drill and make my pilot hole to depth. And then I'm going to take a periapical radiograph and be sure that the pilot drill is parallel to those adjacent teeth. I want the pilot drill to be about this direction right here. To do skull drill ahead of time, I always look at the radiograph before I place an implant or before I extract a tooth, especially wisdom teeth, and decide where I need to cut the wisdom tooth before I extract it. Same thing with an implant. See, the sinus is not a real issue right here. In a perfect world, you'd engage the floor of the sinus because you've got that cortical bone that really stabilizes the implant. So that's about 13 millimeters from the alveolar crest to the floor of the sinus. So my pilot drill is going to be 15. So I'd like to breach the floor of the sinus. And I'm looking from the side as I want to be parallel to these two teeth, these adjacent teeth. Then it looks parallel to both of them. Take a periapical radiograph. So I may turn it just a little bit toward the bicuspid as I go on with my drill. So I'm going to make it 14 millimeters. That was 15 and just barely breached the floor of the sinus. Now think through with me. If I'm using a 14 millimeter drill and I haven't reflected a flap, the soft tissue is 2 millimeters. So the shoulder is stopping on the soft tissue. So if I've got a 14 millimeter drill shoulder, that's measured from the shoulder to the tip of the drill. What's my implant going to be? 12. See, 2 millimeters for soft tissue and 12 millimeters for implant. So from soft tissue, the coronal part of the soft tissue through the floor was 15. So the implant's going to be 12. 2 millimeters for soft tissue and 12 millimeters for the implant in the bone. See, so now when I place my pilot drill, I was tipped just slightly toward the molar. So I'm going to straighten that up with my forthcoming drills. Good. The sinus is way up here. So this is 14. So I'm in plenty good bone. And there's no reason to go to a 20 millimeter implant. It's not going to be more stable or long-lived than a 12 millimeter. So it's a 14 millimeter drill, a 12 millimeter implant, because I've got 2 millimeters of soft tissue and the shoulder of the drill stops on the soft tissue. So the bone, the alveolar crest, is about right here, about 12 millimeters once you subtract the 2 millimeters of soft tissue. So what I'm mainly interested in, I don't want to engage the teeth on either side. See, so that's just about perfect. You want to make the implant as wide as you can because it's surface area, but you also want to keep a millimeter of bone surrounding the implant. So there's a lot of things to think about. If you place implants, you won't have to work crossword puzzles to keep your mind engaged because you're thinking about, what are you thinking about here? What's your skull drill? Don't engage the roots of either of these teeth. Keep this parallel. Then you've already determined your depth of implant. You don't have to worry about a nerve since it's the maxilla. If you did perforate the floor of the sinus, you don't want to perforate the floor of the sinus more than 1 millimeter or 2. Read the article in the Library of Dentistry Master Classes on implant perforation of the sinus. That's not a problem. That's good. So the other thing is you want to keep 1 millimeter of bone surrounding the implant. This is a 4.6 by 12. So that implant, see, the maxillary bone is softer than the mandibular bone. So you can have an implant in the maxillary bone that's wider, considerably wider than the last drill if it's a maxillary implant because it's softer bone. The mandibular bone is harder, so you usually don't want an implant that's more than about a 0.5 millimeter wider than the final drill in the mandible. You're going to torque this again to 35 Newton centimeters. These teeth are going to receive crowns and endodontics at a later phase. So I'm adjusting this so I've got plenty of space for my long healing abutment. You don't want the healing abutment to contact those adjacent teeth. Be sure a little, okay, floss it. So I'm going to cut through a little bit more. I don't care if I cut into my healing abutment, but I don't want it to touch the adjacent teeth. And I'm going to prep these adjacent teeth for crowns in a later phase. So this is the final result. Hello, this video is a small portion of a complete comprehensive video. If you'd like to see this complete comprehensive case and many other complete comprehensive cases, click on the link in the description below. So we're going to place an implant. So see, here's the sinus way up here. So I've got all this space, all this bone. So I'm not worried about penetrating anything. So I'd like to have at least 5 millimeters of bone around the implant. Remember, with implants, it's about surface area. Surface area. So if you've got a wide implant, see, I've got a big space here and not that much length. We've got now some 6 millimeter implants. Those are stable implants. I really have not lost, knock on wood, a root form implant because I don't load them until the implant is osseointegrated for 3 months. This is not an issue right here. We've got lots of bone. I'm looking at the floor of the sinus up here, so no issue at all. But if you perforate the floor of the sinus, you don't want the implant to extend into the sinus, ideally, more than a couple of millimeters. So this is the technique I use. I use a pilot drill, and remember, you've got 2 millimeters approximately of soft tissue. So this is, I believe, 14 millimeters. This is the dentist system. I'm now using the OCO system that also has shoulders on the drills. To me, that's imperative that you have shoulders on the drills. I hate drills in implant systems that just have markings on the drill, and you're trying to look at those markings with water, light, blood, saliva, and every drill you have to look at the markings again. With these, because it has this shoulder, it stops. So once you establish the depth, you don't have to think about it again. So this is the 2.2. See, it's got the shoulder that stops. So think about this. If it's a 14 millimeter drill from shoulder to tip of the drill, what's the implant going to be? The implant length is going to be 12 because you've got approximately 2 millimeters of gingival tissue. That shoulder is stopping on the coronal part of the gingiva. See, so from here to here is 14. So you've got about 2 millimeters of gingival tissue. So you're going to have, I believe in this case we used a 12 millimeter implant. You just go down the line. They're not longer, they're just different widths. So we're just making this as wide as we can, and I'm trying to keep the drill parallel to the adjacent teeth. That's why you want to take I usually take a periapical radiograph every other drill. So you can see this is parallel to these teeth, and it's right in the center of the edentulous space. So before I start, I make a little magic marker dot right in the center. I don't use a surgical guide with just a single implant like this normally, because I've got guidelines on each side. If it's a distal extension, then many times I'll use a surgical guide because you don't have a distal tooth to guide you. So we're just making these wider, and then I take the drill out and I'll take a look at the shaft of the drill in relation to the adjacent teeth. And like I said, about every other drill, I'll take a periapical radiograph. See, so that's just about right on the money. This is the 12 millimeter implant, a 4x6. So remember bone, surface area and type of bone. The hardest bone in the mouth is the mandibular anterior. The second hardest bone in the mouth is the mandibular posterior. The third hardest is the maxillary anterior, and the softest bone is the maxillary posterior. So this is the softest bone in the mouth. So anytime you're placing an implant, you want the width of the drill to be a little bit thinner or less than the width of the implant. So for instance, if I was placing a 4.6 width implant, what do you want the drill to be? You want the drill to be about a 4.0 or 4.3. If it's in that soft bone, there can be a greater discrepancy. You might even have a drill that was a millimeter thinner, less diameter than the implant. You'd like to torque it to 35 Newton centimeters. You just screw this to place as far as you can, then you're torquing it to 35 Newton centimeters. So if this is a 4x6 width, you want the last drill to be probably a 4.0, 4.2, something like that, something thinner than the implant. It's not an exact science, it's just you want the drill to be thinner than the implant. The implant's going to be wider. It's rather like putting a wood screw in the wall. You make a hole with a nail, then you put a wood screw in that's a little wider than the nail hole. Okay, so see we're torquing to 35 Newton centimeters. I like a long healing abutment. Now, a lot of people reflect a flap, and I did that for many years. The problem with reflecting a flap is you've got to put a flat healing abutment on the implant and cover it with the flap. So when you come back in 3 months after the implant is osseointegrated, you've got to take a core to uncover the implant, and then either take an impression. If it's in the aesthetic zone, you've got to anesthetize the patient, remove the implant, all that. If you go through the soft tissue and don't reflect a flap, then you're putting this long healing abutment through the tissue. So while the implant is osseointegrating with the bone, this healing abutment is developing the emergence profile of the gum. The gingival tissue is creating a perfect emergence profile. So when you come back to take the impression in 3 months, you don't even have to anesthetize it 99% of the time. The emergence profile has formed, so when the technician gets the impression, the technician knows that's the emergence profile, that's the height of the gum, and he can create a more exact implant, abutment, and crown. So I'm not saying you're doing it wrong if you reflect a flap, but since I've been doing it this way, it's very precise, a lot easier on the patient. You know, they don't have to dread coming back for the impression. And if it was in the aesthetic zone, you'd probably have to place the long healing abutment after you do the core of through the tissue and let that emergence profile develop for a few months before you took the impression. This way, when the patient comes back after 3 months of the implant being in the bone has grown into the implant. Think about a broken bone healing. How long does it take? 2 months? So we're giving it 1 to grow on. I'm not loading it at this time. It's just the healing abutment. So in 3 months, the bone has osseointegrated with the implant and the emergence profile has developed. Very smooth. You're just going to hand tighten this pretty snug. So it's good spacing on each side. That's about ideal. See, and here's the sinus. I wouldn't be, if the sinus was here and I had 2 millimeters of this into the sinus, that wouldn't bother me at all. That's the Dental Minute. These techniques work, and they work every time.
Are you ready to take your dentistry practice to the highest level possible? Of course you are! Subscribe right now to dentistrymasterclasses.com, where you will get Dr. Cutbirth's greatest work and best cases. Here's what you're going to get when you subscribe to dentistrymasterclasses.com. Incredible comprehensive cases not seen in Dental Minute videos. You will get an organized library of all the Dental Minute videos and Dentistry Masterclasses, comprehensive cases for study and reference, before and after photos of Dr. Cutbirth's fantastic restored cases. And all of this, I repeat, all of this is just $40 a month. This is something you cannot pass up. Subscribe right now to dentistrymasterclasses.com.